All right, so we can go ahead and begin. Welcome everyone to today's shadowing session. Today we have Dr. Mona Stone, and she's an oral maxillofacial surgeon, and we're super happy to have you here today.
Thank you so much, everybody. Welcome to this session. I guess you can call it the virtual shadowing, but you can call it just kind of a presentation. And as you'll see in this presentation, we're going to go a little bit back and forth between a little bit about me as a person and a little bit about stuff that I do and OMFs do, in general, just to get a feel for what we do. We're a little bit of a misnomer, misunderstood field. So I'm really glad that, I get to have this platform where I can share with you guys what I do. So here's me. I'm the owner of Stone Surgical Arts, which is a full-scope oral maxillofacial surgery clinic. We have 2 offices in North Dallas area. This is my family. I have 2 little ones. They're 1 and 4, and they just went to sleep, which is lucky. So a little bit about the path to OMFS. I actually was an engineering major in undergrad. I went to Washington University in St. Louis, and I majored in biomedical engineering at that point. I actually at the end of my road, I had decided at that point I wanted to really be a research scientist. So at that point, I wanted to go and get my PhD. So I worked for a year as an engineer, and I just figured that was not really my call. I really wanted to use my hands, and I wanted to work with patients directly. So I figured just gonna open up the chat so I can answer you guys also as I go as well. But I'm gonna try to answer most of your questions at the end, okay? So, but keep posting questions and I'll go through them at the end. So that was not my calling, and I decided to shadow an OMFS and other peeps too. And I really, really understood what OMFS did. My first shadowing case was a gunshot wound to the face, and I was really drawn into how everything went together, what it took to put someone's face back together that had just gone through such a traumatic injury. And I figured that was my calling, and that's what I ended up doing. Well, let's see. Okay. So the traditional way to become an oral maxillofacial surgeon is to go to dental school and then go to residency. So I went to dental school at University of Missouri, Kansas City. At that point, I applied as a 4th year to several different residencies. I ended up not matching my first time around, and that's a whole different story. I ended up actually doing a year of internship at Truman Medical Center in Kansas City, and did a ton of things and reapplied, ended up matching at my #1 spot at Broward General Medical Center in South Florida. And I spent the next 4 years of my life in Broward General Medical Center. And from that point on, I met my husband, and my husband and I moved up to Northeast to Lancaster County in Pennsylvania. And we ended up I ended up working there for several years before moving down to Dallas. And this is just our office, our new office that we just opened in Westlake, Texas. So like I said, I'm gonna go a little bit back and forth with some cases and just keep posting your questions, and I'll try to answer them really towards the end. All right, 64-year-old male who was presenting to us status post fist to the face, and he's pretty healthy. He's got a social history of 1 pack of tobacco per day and works as Sonic. And what happened was that he just basically got hit, didn't think too much of it, and then sought treatment 3 days after because he was having pain associated with his mandible. So typically, what's called a panoramic X-ray is a very diagnostic X-ray for not only teeth but also bone. and this is very diagnostic for me as an oral maxillofacial surgeon in order to see what's going on. And here you can see the patient's dentition. Here you can see the patient mandible. And if you guys can see my pointer, you can see right here, you see this disruption in the bone. So that's a fracture, okay? And this is another fracture. So this patient has two fractures, one in the angle of the mandible on the right side, and this is a body of the mandible on the left side. This is a very typical presentation of someone who gets, you know, fist hit by someone, or you can call it sucker punch. They can really end up with a pretty bad mandible fracture. And typically, if you have your wisdom teeth, your chances of having a fracture is a lot more. So that's why nowadays you have more and more people, more dentists, general dentists referring patients to oral surgeons to have patients' wisdom teeth removed, because presence of those wisdom teeth leads to having worse fractures and also having just more chances of breaking the bone, because the presence of the tooth can compromise, especially people that are in contact sports like athletes and the ones that play basketball, football, and those people are highly recommended, and they do get their wisdom teeth removed, but also most other people do for various purposes, but also for this purpose. What we see clinically in patients like this is, well, the first thing you see is really bleeding in the mouth, but also on a visual examination and palpation, you can really appreciate some laceration, some mobility to the mandible, and some malocclusion, meaning the bite of the patient doesn't come together. But there are some other things that could happen from a mandible fracture or for any facial fractures as well. You can have airway compromise, you can have damage to the nerves, you can have all these bones that are very, very important in functioning can actually be compromised. And that's, like I said, one of the things that we look for as oral maxillofacial surgeons. This is why our training in dental school becomes very important, because we understand what occlusion, what bite means, because bite is what actually really presets the face. And well, teeth are a huge part of the face. So the bite and the way the bite, and we call it occlusion, comes together really determines how everything as far as a like a facial fracture or anything like that comes together. Some of the other signs and symptoms that we can see with these patients that have not only mandible fracture, but also other facial fractures, of pain, tenderness, palpation, swelling, step defects, mobility, hematoma, and lacerations. So as someone typically like this, we would approach it with what we call an intraoral incision, which you guys can see over here. So we basically make an incision inside the mouth and expose a fracture, which you can see here, and then we typically plate it with how many ever plate you need to. Residency reality. So, people work really hard in any type of, medical field or medical student, dental student. But, you get to residency and, you work really hard, right? You go at it, you try everything, you get to your number one spot in your, but that's where the struggle really starts. Residency life is not easy, okay? But you learn so much, but it's not easy. There's hours and hours and hours that you put into being a resident. And then after residency, there's so many things that come in mind, like paying off your debts to become financially free, because obviously college, medical school, or dental school, and all of that is costly, right? And not everyone gets full ride scholarships or scholarships of any point, any amount to really support that. So then choosing the path, there are so many paths in any type of really, medical field after your, or surgical field, I should call it, after you're done. You can be in academics, you can be in private practice, it could be both. And then there could be so many different combination of these. You can be hired by a hospital, you can be hired by a clinic, you can be hired by corporate, or you can have your own thing. And then the other thing is really understanding as far as especially females go, you know, how we're going to start our family. What is the perception in residency? A lot of residencies are starting to become more and more and more open to residents having kids while in residency. However, it takes obviously time away from training, but also takes time away from the other residents who have to fill in the shoes of the resident who's pregnant and maybe on maternity leave. And then after residency, there's other things too to consider, like boards and then work. And then really the other thing to keep in mind is digging into true passions outside of work. I pulled this directly from Wikipedia because I wanted to know what, I guess, the layman person would think an OMFS does. Like I said, we're kind of a misunderstood field, okay, because we're a dental residency, but we're also a medical residency, and we're also a surgical residency. So we're like a kind of a middle point between all these kind of like these different fields, and we, as a result, we do so many different things. And also there's some crossover, which I think I saw some questions in the chat in regards to that, and I'll answer those in specific. But there are some certain things that we do as OMFS, and then there are some things that we do in plastics do, or ENT does. So we all kind of some of the things that we all do are really almost the same or similar type of a training. Cosmetic surgery, orthodontic jaw surgery, facial trauma, oncology, and this could be like head and neck oncology, also could include skin oncology or skin cancer. And then there's benign pathology like cysts and tumors of the jaw. And then there is congenital defects like cleft lip and palate and cranial vault. And then there is TMJ and facial pain or myofascial pain. And then, like I said, there is dental alveolar surgery, which really includes wisdom teeth, impacted teeth, and those type of stuff, placement of implants and those type of stuff. So there's a lot of different things that we do as OMFS, and management of head and neck infection. Going just to jump a little bit before I go into some case presentation, I really want you guys to think right now. We're all very focused on our careers, and that's really good. But I really want you guys to think about what is your passion, and then really make some time for it, because life is so short. And if you're so focused on one thing and you're not really making the other part, which is your true passion, or just some hobby or something that you're happy about, then life has really just no meaning. Life and work become the same. There's really no balance. It's just all like work, 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 or study, 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 right? So just want you guys to think, I didn't really realize what my true passion was until later. I have a huge passion in motorsports and those type of things. So, but I want you guys to think what your passion is. It doesn't have to be the same as me or anybody else. It can be whatever. Also, another passion of mine is nonprofit organizations, and this is one of my organizations. It's Real Heroes Need Masks, where we donated a ton of masks and we raised a bunch of money. And another organization that we founded is the Virtual Mentor, which is a great website for information as far as mentoring and just advice for pre-med and med students. All right, so we're gonna do some fun cases, and this is not meant to be for like a quiz or anything. It's just meant for me to present to you guys some of the things that I do on a daily, just so you guys can understand what we do. Okay, so this patient presents with 1 week old basketball injury to her mouth. And let's see if I can point to, obviously you can see this is the front area, the teeth, and you can kind of appreciate here, it's got a little bit of a swelling, and here, over here, you guys can appreciate a little bit of a swelling. This is a very, very minor, simple case of a patient that basically has had a tooth fracture, and a tooth fracture can lead to a simple abscess. And someone like this will typically need, the source of the treatment, the infection treated, which is typically the extraction of the tooth, draining of this little tiny abscess and then replacing that tooth. So so obviously this case does not need to be admitted to the hospital or anything like that. This is something that we see typically in a clinic setting, and we take care of it there. And then, but infection and head and neck infection management is one of the big things that I as an OMFS, or we as OMFS, really cover. And there's just different things that we need to consider as far as the severity standpoint goes. So the anatomical location, the rate of progression, and then airway compromise, because we're in the face, and if you have swelling in the face, it can, depending on where it is, it can go all the way down to the neck, to the mediastinum. And then there's some frequent pathogens that we deal with in the mouth, and strep is really one of the most common. I threw in another quick case in here. So, in between doing some dental alveolar surgery, I also do some cosmetic surgery. So this is again a patient that presented to me with a complaint of upper eyelid excessive skin, and just wanted a refreshed look, and just did not want to have that extra skin over. And so her treatment was what's called a blepharoplasty, which is an eyelid surgery, which is removal of the extra skin as well as extra fat. So this is, you can see we're marked it here. We've removed here the extra skin, as well as several different fats that are around the upper eyelid. And here she's presenting to us 10 weeks afterwards. Now, another fine case. Okay, now this is a patient who looks very sick. All right, so I get called at a hospital about this patient, and this patient's insulin-dependent diabetics is someone who's sick, and it just has this one-day history of swelling. So obviously, you guys can appreciate that he's got some real major swelling going on right here in his mid-face area and his right side of cheek area, but also around his eye preceptally. So this is a little bit of more of a pressing issue. So where is this infection coming from? And then what do I need to do? Who do I need to talk to? This patient's diabetics, obviously they're immunocompromised, and I get a call from the hospital about this patient. What do I need to do? So in my head, I go through all these things and go through their medical history and what's the source of the infection. The source of the infection in this patient was a tooth, and it's typically a tooth. It could be also sinuses. It could be a tooth, or it could be something else. But typically, someone like this is presenting with a tooth infection that's really, because of their diabetes, is not, nothing can be controlled, so it's progressing pretty fast. So definitely, this is the step 2 that I was just talking about. So we really pay attention to this type of stuff. Immune system compromise is huge, and some of the things that are causing it are these, as stated. Most common is diabetes. So obviously, we really need to get on top of this, because get on top of the blood sugar control, because if we can control that, then we can control the infection better. Here's another fun case. Now, I treated that patient, took out their tooth, drained the infection, put them on some antibiotics. They're happy in the hospital. I come back to my office, and now I have another patient who's presenting with this little tiny area in their cheek that is basically just kind of swollen. It keeps going up and down, and you can appreciate it removing here. And here is our specimen over here. This is what's called a mucocele, which is essentially an injury from a trauma to the cheek. It could be as simple as biting. That is caused the duct of the salivary gland in the left cheek to be injured, and the saliva gets inside of this salivary gland, which is super inflamed. You guys can see it here. And it keeps going up and down because it gets filled with mucus from the saliva, and then it bursts when it doesn't have enough more space. So it just keeps going up and down, and treatment for it is to remove that salivary gland, as well as the other inflamed salivary glands around it. And then here's another case, and that I did in the hospital. And this is another patient. Again, you can appreciate a little bit of a swelling in this area, but this patient actually ended up having what's called a pleomorphic adenoma, which we can see the specimen on this side. And this is a benign salivary gland tumor that we removed in entirety. I want to also point out that there's definitely some social media advocacy that I have going on, but I really encourage you guys to really use, especially in COVID time, to use social media as your kind of good go-to place to connect with people. So I've connected to a lot of people via social media, so I find that very, very fulfilling as well. Here's another patient that could present to us with this type of facial swelling. Okay, so this type of facial swelling, again, it's rapidly going. They also have diabetes, their hemoglobin A1C, which is something that we look for to really understand whether their diabetes is controlled, is pretty high, and they have, again, some severe periodontitis of their teeth. And so, we can really appreciate this fullness in their face, this swelling, and this patient doesn't look comfortable, potentially they're airway compromised. And then we drain it. So this is what's called Penrose Drain right here, okay? This is a patient that's drained, and looks like this patient is actually intubated as well here in this picture. But they're not really progressing well. I mean, you can see her skin is starting to, even after the drainage, his skin is starting to look 5-day post-op very, very dusky. So this is something that's starting to become more and more serious. Even though that he was treated, his infection was drained, he is not. He's progressing. So this was a case of what's called necrotizing fasciitis. This is that flesh-eating disease. If you guys have ever heard of it, or may have read it in news, sometimes, especially in the lower body, we see it with people that like go to a lake and then all of a sudden, something got in their wound and then now they're losing a leg or a limb. So it can happen in the face as well, and it can happen in the neck, especially as a result of an infection in especially an odontogenic infection, or could be a skin infection. And a patient that is immunocompromised, like this patient that has diabetes, that they do not heal well, and the type of bacteria associated with it is pretty variable, is pretty I guess it's not responding to normal antibiotics. It can progress to what's called necrotizing fasciitis, which is basically the skin really falling off and dusting off and progressing pretty quickly to just basically skin death. And so here you can see the skin is just kind of falling off, and here we're going in there to debride all the dead skin. And here are some pictures of the debrided skin. Now we have starting to have some healthy wound tissue. This can happen in kids as well. You can kind of see it in here too. And so this is something it's a metabolic change problem that we need to really address, not by just addressing what's going on locally in the face and the body, but also systemically by fluids and giving them the appropriate medications. And again, this is really worse, and this is something that really, really can kill people and does kill people. And my years of doing what I do, typically these patients have a very high rate of mortality. They don't really unfortunately live long. Here's another fun case that we just did, and this is the patient that presented to us after repair of what's called an orbital floor fracture, which is the bone around the eye. And he ended up with what's called, basically he has more scleral show, meaning more eye show on this side versus the other. And this is because he's just got some scarring. So we went in there and just repaired his scarring. Last case is another one of these cases where, again, have a super rapidly increasing swelling. Okay, this is 8 p.m. on this side, and then we have the midnight, and they're just really getting worse and worse, again, from a tooth infection. And this is something that we really worry about, because now this patient can't even see and starting to have some decrease in consciousness. This is what's called cavernous sinus thrombosis. This patient is the infection has traveled all the way back to the cavernous sinus. Okay, so that's pretty bad. It's essentially the brain. And almost the brain, I should say. And so this is a very, very serious condition. Again, another serious condition that we deal with as OMFs. One last case that I'm going to throw in there is a cancer construction case that we did. So this is a patient that presented to me as a lower lip cancer. As you can kind of point it here, it's just kind of fungating mass that's in there. And obviously there's one thing to remove it, which is, we marked it here and you can see it remove here. And then the other thing is to flap it, to basically kind of put it back together. And we did what's called a carpansic flap to put it back together. And believe that was my last light. Kind of fly through those. And that is all I have. There's so many things that I can discuss with you guys as far as what I do, but I just throw in some of the fun cases out there. And let's see, I'm going to answer some of these questions and feel free to add more to the chat. Okay, so how does OMFS compare and stand out from other dental careers? How do we stand out? I mean, I think that we stand out as far as what we do. It's very, again, we're a subspecialty of dental as a dental career, dental field. And again, what we do is pretty specialized to the surgical aspect, but again, it's pretty broad, as well as you guys can appreciate. We are the to-go people for any type of, I should say, complications. We're the to-go people for any type of emergency. And then obviously we're the to-go person for, these type of infections that are progressing pretty quick. So we all have a really good, try to have a good relationship with our other dental colleagues because we all work together to, treat patients. Could age affect any part of the surgery? Yes, age does have an effect. Obviously, when you're younger, you heal quicker. So I typically like operating on younger patients. Do you know any downsides from the experience of being an oral maxillofacial surgeon? Yes, it does take a lot of time, obviously training. And obviously from that standpoint, you don't really get to start a quote unquote normal life earlier in life because you go through all these years of school and then training and then potentially fellowship afterwards. So that's a downside. What are subspecialties under maxillofacial surgery? Subspecialties are cosmetic, facial. So these are some of the, I guess, subspecialties that you can subspecialize. So yes, you can subspecialize as an OMFS. You can become a cleft surgeon. You can become a cancer surgeon, so head and neck cancer surgeon. You can do a fellowship in that. You can do a cosmetic fellowship, cosmetic surgery fellowship, where you just do cosmetics for a whole year or more. You can do a TMJ fellowship. However, a lot of us do treat TMJ in general. So, but those are some of the subspecialties of OMFS. Do we do surgeries involved in the neck? Yes, all the time. Does OMFS involve cutting bones? Like when adjusting Invisalign jaws? Absolutely. The bones is where we're at. And as a matter of fact, some of us even, we work with plastic surgeons and they do like some of the soft tissue stuff. And then, we do the bony stuff and some of us, we do all of it, so, but yeah, a lot of what I do is cutting bone. I cut bone all day. So we're the orthopods or orthopedic surgeons of the face because we cut bone all the time. What do you think the main difference between OMFS and a dentist is? So an oral maxillofacial surgeon is a dentist, is not a general dentist, a dentist is for a subspecialty of dentistry, but also is a physician. So the difference is okay, so it's like, I'll give you an example. So what's the difference between a cardiologist and a PCP? So that's their specialty is cardiology. So that's how I'm going to compare it. An OMFS is oral maxillofacial surgeon is a subspecialty of dentistry / is also subspecialty of medical. So we're specific to the face, head and neck surgery, and those type of stuff. What would you say was the most common type of surgery that we do? Yeah, most common surgery that we do is actually, in terms of numbers, is wisdom teeth surgery, because let's face it, everybody has wisdom teeth that need to be removed. And then the second most common, all depends on what, again, which practice you're looking at, but as far as dental alveolar surgery goes, it will be dental implant surgery. And as far as everything else go, would be facial trauma surgery and head and neck infection management, which we talked a lot about today. Okay. Can certain places have a higher need for oral surgery than others? Yeah, absolutely. The community hospitals, especially downtown hospitals, have a whole lot more needs for it. And typically those are associated with residencies, which is good. They get high volume of patients, indigent patients and those type of stuff. So they really need an oral maxillofacial surgeon. So as a result, a lot of times the hospitals actually hire OMFs for those hospitals, and typically, like I said, they're associated with the residency as well. What lead to you choosing OMFs or other specialties? I kind of talked about that a little bit, my interest in facial trauma surgery. What is the difference between your residency and that of a dentist? So a general dentist does not go to a residency unless they go to what's called a GPR, which is a general practice residency, or an AEGD, which is advanced general. It's the same thing essentially, and they do like a year of just kind of like, I guess, learning more about being a dentist. But okay, OMFS, we actually in the 4 to 6 years of the residency that we go through, it will involve many different medical surgical rotations. So we essentially we rotate with trauma surgery, with anesthesia, with ENT, with plastic surgery, with medicine, and yeah, so many different subspecialties that we like rotate with, just like any other medical residency would. Okay. What was that? My second question is, why do you choose to become an OMFS, which I answered that. Were there any experiences you have with patients that are difficult to handle? In terms of their health, I mean, it's always interesting when we're dealing with the health of the patient, and people don't really want to take care of their health. I mean, there's some specific examples that I can give you, but yeah, it's hard sometimes dealing with some of the patients that don't want to take responsibility for their health. So it's important for them to take responsibility at their hands. What do you enjoy most about my profession? Really what I do, being full scope, what skills or talents I have, what are most essential, being good with your hands and really paying attention to details. What is the difference between maxillofacial surgery and plastic surgery? Great question. It's pretty broad. Maxillofacial surgeons, we're specialized in head and neck surgery. Plastic surgeons, they go through general surgery residency, or they go through plastic surgery residency. They go through general and then plastic surgery residency. So they are trained to do essentially surgery on any part of the body. But plastic surgeons, just like OMFS, they sometimes subspecialize, or they decide to do only surgery on upper body or lower body or face. So all depends. Did you consider other fields of surgery before deciding? No. How long does it take to become an oral surgeon? Over 13 years, depending on, again, a length of your residency, and then if you decide to do a fellowship. What age would I say is appropriate for people to get the wisdom teeth out? 16, 15, 16 is great. What is the most satisfying part about my job? Dealing with my patient. Does blood pressure affect the maxillofacial surgery that's performed? Yes. Sometimes we do have to delay elective surgeries if their blood pressure is not controlled. And then what age do wisdom teeth erupt? It all depends on, some people have earlier eruption. Some people have later eruption, but typically around 12 years, we start to see some formation of the teeth, and then they start to erupt. Again, depends. Sometimes they don't even erupt. They stay impacted. What is the difference between plastic and OMFS? We answered that. What is the most fun of your favorite part of being OMFS? Really, again, my patients and just all the various type of things that I deal with on a daily. And then what made me more interested in OMFS? I did answer that is facial trauma surgery. And what is your biggest advice for maintaining good oral health? Brush your teeth and floss daily. Was there any other medical jobs you were interested in? Not really. What is your favorite surgery you've done in your job? Is orthodontic surgery. That is all the questions that I answered for you guys. Any more?
It looks like that's about it.
Awesome. Very good. Well, I want to end with this picture, and this is us on a road to success. And I want to tell you guys, we look and you don't ever lose the sight of that light at the end. There is a light at the end. You work hard, you're going to get to it. There's going to be some hills on the way. It doesn't matter. You're going to get through it. Life is not easy, but always look at the light at the end of that tunnel.
All right. Thank you so much, Dr. Mona Stone. That was a very, very insightful session. I definitely learned a lot. But yeah, thank you so much. And for everyone who's still watching, the Google form for today's session will close at 9:55 p.m. So make sure to get that in order to get your shadowing hour. And thank you once again.
No problem.